All right. I I see people are still coming in, so I'm giving a few seconds to get us started. All right. It's 11:01 a.m. Here in Chicago. It's a cloudy day, but I really appreciate you all being taking the time to be here with us for yet another edition of CPT Dev Chat. Those of you who are new to this, this is our community of developers that have been working with CPT developer program for quite some time. They are in various stages of their journey, whether they are just getting started with launching a new product, building a new tech, or well on their way on implementing multiple solutions using CPT and a variety of different things. We use this forum to really engage with our community to talk about different things where AMA can help, where others can help, and maybe they even learn from each other. That's essentially has been the goal of this community. Uh, like every time, we are excited to bring you a relevant topic that we hope that you find value in, and really excited to get started. But before we get started, a couple of disclaimers. The contents of this webinar represent the views of the presenters and should not be considered to be the views of or policy of the AMA. Company names or logos cited in this presentation are intended to demonstrate specific point and technologies only and not an endorsement of any such entity or any product service by the AMA. Please note the purpose of the CPT Dev Chat is informational only. You should consult a professional advisor for specific medical, legal, financial, or other advice. This CPT Dev Chat and CPT are copyrighted by AMA. And please take a moment to carefully review this notice. With that out of the way, let's really get on to the engaging part. Quick update, add your questions Q&A at any time. Raise your hand and unmute yourself when called upon. Session recording will be available on the AMA Intelligent platform, so you can come back and review this fantastic session. No definitive feature timelines unless explicitly stated. So, yep, that's where we are. We have an exciting lineup for you today. So what's on the agenda? Next slide, please. Yeah, so we're going to do CPT developer program updates. Dennis Kasban from AMA will walk us through where we are with our CPT developer program currently. Then we have Duke Institute of Health Innovation team with us. Really excited for them and really grateful for them to be here. The mission of DHI is to catalyze transformative innovation in health and healthcare, and to help cultivate a community of innovation and entrepreneurship across Duke University as well as the health enterprise. And they've done a tremendous job, and really excited for their session on health AI partnership. And then we'll have a community discussion, right? So let's get started. Dennis?
Thanks, Andy. So the program continues to grow. We can go to the next slide. We can see we have over 3,500 people that have signed up for the dev program. This is really just the community to be aware of events like these, and it helps give us a sense of who's working with CPT in different ways. And then to a more specific insight into that, the dev licenses that we've issued really dig into what people are working on. So thank you very much for applying and using CPT content in a lot of interesting ways. We'd love to hear what you're working on, how we can support it. Some product features have definitely come out of your inputs, and so keep those up. We definitely want to support kind of whatever you're working on. Some of the more expected, claim management and financial rev cycle type software that's coming out of the dev licenses is moving the industry forward. But then there are a lot of fun things that even kind of like coding games and things like that. But we can't really get into new developments without input from you. So keep it up. Speak to us. Let us know what you're working on, what we can help with, and how we're doing. So next slide, please. A few different resources just to call out here. You can scan these with the QR codes. The Dev program for anybody on the call who isn't signed up already. The middle one, a few of us gave a presentation at an HL7 event last year, really CPT for health IT developers. One of our focus areas is taking the way CPT content is structured and making it more usable in more tech-forward applications. And there's a lot of work to do there. So we definitely need your input on what's working, what's not, how we can improve documentation and formatting and things like that for your uses. So take a look there. It should be an insightful listen. And then not specifically relevant to the dev side, but also on the HL7 kind of tie-in, we just put out a new prior authorization physician survey. So it really highlights the challenges that physicians and their staff are having with prior authorization, and that bleeds into a lot of the work that we're doing, a lot of the work that you are doing to develop new solutions around this. And so kind of those last two, tie in because there's a lot of HL7 standards work to address prior authorization challenges as well. So take a look at those and let us know if you need anything else there. All right, that's it for me. So I'll kick it back over to Sandeep and the Duke team. You're on mute, Sandeep.
Thanks, Dennis. Yeah, I'm sure you're as excited as I am and didn't even notice I'm muted. But yeah, the topic is so relevant. We are going to talk about best practices for AI vendor engagement with health systems. And I'm really grateful for Suresh, Alifia, Mark, and Sanat to be here with us today. I'm going to do a quick round of intro. We're starting with Suresh. I think I could spend an hour talking about Suresh's accomplishments. He's an associate dean for innovation and partnership for the School of Medicine, and works as a program director for the Duke Institute of Health Innovation, which we'll refer as DHI here, right? And he's had a fantastic career. He leads strategic initiatives that drive innovation for healthcare delivery, education, and research, collaborating closely with the Duke leadership, as well as external parties. His role involves evaluating opportunities, analyzing markets, guiding global and domestic partnerships as well. He's had a fantastic career, as I was saying, across academia, consulting, venture capital, private equity, and entrepreneurship. So his PVC experience includes product and technology due diligence, deal structuring, portfolio company management, he's named on over 20 US and international patents and holds degrees in computer science, corporate finance, informatics, and engineering. So we're really, really excited that Suresh is here with us and has graciously agreed to share his thoughts on this topic. Next up is Mark. Mark and I met Mark last year and have grown impressed ever since. He's the population health and data science lead at the Duke DHI. He leads the interdisciplinary team to implement AI-powered technologies that improve chronic disease management and inpatient care. He's a co-inventor for software for scaling machine learning in healthcare, and he co-leads the Health AI Partnership, which we're going to talk about today, and directs the DHI Clinical Research and Innovation Scholarship. His work has been featured in major outlets like the Wall Street Journal, the MIT Tech Review, and has been advising national organizations such as White House, OSTP, etc. Right. So he was appointed to the Health Information Technology Advisory Committee and testified before U.S. Senate as well. Mark holds an MD and MPP from Duke and BS in mathematics from UCLA. So thanks, Mark, for being here. Next up is Sana. Hi, Sana. She's a research and product manager at DHI. She collaborates with colleagues with external partners in the AI healthcare implementation strategy. And she's really committed to be responsible, bring tech-inspired solutions for care delivery systems, needing more traditional infrastructure and expertise. Before joining DHI, she was in graduate school focusing on global healthcare, innovation for public good, uh, and she's really excited to be part of this journey in her own words. So outside of work, she loves taking long walks and appreciates cup of tea, which is my favorite beverage as well. So that's lovely, Sana. And last but not the least, Alifia. I think Alifia has been this evangelist ever since I've met to talk about DHA and gotten me excited about this topic. I really enjoyed our interaction so far. She's the leading the innovation portfolio manager for DHI, leads the project management implementation of externally funded projects. These projects bring together cross interdisciplinary teams of domain experts, community representatives, academia leaders to cultivate an ecosystem that promotes safe, effective, responsible use of AI in healthcare. Uh, most of her projects are around innovative data science techniques that help solve challenging the clinical problems which we're all uh, privy to. And together with DHI team, she hopes to build products that use technology to create value for patients. She has worked in academic research administration for more than 10 years now with Duke and Stanford. And before even joining DHI, she was managing the Duke's Department of Psychiatry and Behavioral Sciences. And her long-term goal is to leverage technology to improve the patient care by making healthcare more equitable, effective, and safe to use. I Outside of work, she told that she loves to go traveling to new places with her husband and her two daughters. And she's also a chai addict, I think, which tells her love for tea and as well as Sufi music. That's something that stood out to me. That's one of the style of music that always gets me. I love that music too, Olivia. So lots of commonalities there. With that, and such brilliant team in front of us, I'll get out of the way and hand it over to Sana.
Thank you so much to the AMA team, Sandeep, Dennis, and Vanessa. We're really happy to be here and to engage in this conversation. As Sandeep mentioned, I'm joined by Suresh, Mark, and Alifia, and we're all here to answer any questions that you have. Next slide, please. So this is just a quick overview of what we'll be talking about today. Suresh will start us off with the Duke Institute for Health Innovation and our innovation approach, and hand it over to Alifia, who will then talk about our Health AI partnership, which has been a fantastic community for developing and implementing best practices. And then we will go into talking about transparency, building trust, and how to navigate vendor relationships in the current AI landscape for health systems in particular. Next slide. Suresh, I'll hand it over to you.
Good morning and good afternoon, everyone. Thank you again, Sandeep, Dennis, and Vanessa, for the opportunity to present here today and share with us your views as well. Thank you. A very quick background on who we are. DHI, Duke Institute for Health Innovation, was created roughly about 12 years ago, and we've been driving transformative innovation in health and healthcare for a decade or so at this point in time. Initially, it was a slow process, but then certainly we are in full momentum at this point in time. Our focus has been solving real-world problems, developing novel solutions in a working health system, and then putting those solutions into practice, into existing workflows, doing the research to show the utility, the clinical utility and the economic utility, and then scaling them through into our community and also externally as well. And then through this particular pathway, we foster a community of entrepreneurship as well. So we do take a very different approach, a user-centered approach, design thinking methodology is put into practice. We very closely work with our clinicians when we develop our solutions. Many a times we work in their workspace to truly understand and identify the nuances of the workflows. Like all of us know, digital health doesn't fail because of the solution. It fails typically because it doesn't fit the workflow. So we pay a lot of attention to that particular piece and then put things into practice. So that's how we've been iterating our solutions, and we've been successful in deploying many solutions. So our core set of activities fall into these 4 buckets: implementation, health delivery science. That is pretty important in terms of putting something into practice. Certainly a lot of attention in health and health technology. It used to be called digital health, and now it's certainly a lot of emphasis on data science, and then a lot of work in AI, both standard basic set of AI to generative AI pieces as well. We certainly provide an immersive opportunity for our leaders, for our students, for residents and fellows to work with us in terms of how does one really drive innovation in a complex healthcare system, and on top of that, how do you really drive change management so that adoption and use of solutions can be put into practice. Over the years, we have developed a lot of best practice, both in terms of innovation, data science, AI, etc. And those are things that we truly share broadly, both like locally and at some level nationally as well. Mark has been engaged in terms of dissemination all the way up to the Senate Committee, Finance Committee as well. So we've been doing this for a while. Next slide, please. In terms of sourcing of innovation, we have 2 different pathways for sourcing for innovation. One is a structured approach where we put out a thematic area each year, and we get a bunch of proposals directly from our frontline clinicians. We review them, have a rigorous process, and then we work with them closely. We become a single team in terms of really developing the solution and put that into practice. It could be anything as simple as a simple process, but these days, it's heavy emphasis on developing AI-based solutions and putting that into clinical practice. So that's what we've been doing. We have reviewed so many proposals, and we've been doing this for at least 12 years now. The right-hand side, what you see is a little bit more ad hoc, but it is pretty much a Shark Tank, where many ideas which are pretty close to commercialization, we really bring those projects onto the forefront, and then we make a necessary investment internally, get them over the finish line so that a company can be created and ideas can be scaled. Can be both internal and external ideas as well. So this is we've been doing for the last few years. We had to stop during COVID, but then we have created about 12 plus companies over the years. Next slide, please. We wanted to share with you a lot of projects that we've been working span all the way from inpatient setting to directly into the community side. So we have done many such projects and put things into practice. This is just the AI pieces or data science pieces that you have in here. You can see earlier days, we were looking at simple AI ML models on the bottom side, right? Simple pieces could be a simple regression model. But these days, there is quite a bit of emphasis on use of proper AI, agentic AI, large language models, and certainly prior authorization. Those type of things certainly fall into the realm, and we have developed many such solutions, put that into practice. And certainly, you can see it directly affects the community side as well. So we have developed solutions from inpatient to community, which in this process has helped us learn what the community needs, what the internal community needs, and what the best practices are. And that's how we've been, I would say, very interested in how do we scale the learnings both internally and externally through a network. And that's what Alifia is going to talk about in a second. Moving on to the next slide. So the guiding principles that we have are essential for driving effective innovation within our organization. The first one is build to show value. This ensures that our efforts are fully aligned within our institutional strategy and also making sure that we can deliver tangible benefits. And integration becomes extremely important in this particular case, because without integration, most of the solutions do not hit the workflow at all. So we want to make sure that we can work not only within the specific clinic or hospital, we can scale across as well. And scaling innovation requires a good amount of planning of the infrastructure and making sure that everything is built in a modular fashion so that not only that we can scale it internally here, we can scale it externally as well. And all this has to be done in a responsible fashion. This is something which we hold near and dear as we take, especially when it comes to AI, responsible AI development and deployment is important. And this is something that we do very diligently here at Duke. And with that, I'm going to hand this off to Alifia to talk about Health AI partnership, which came out of some of our efforts in terms of developing best practices. Alifia.
Thank you, Suresh, and thank you to the AMA team for having us. Very excited, and would love to hear from the attendees as well during the Q&A session. So talking about the Health AI partnership. So as Suresh was mentioning, DHI had a lot of experience integrating, building solutions for the frontline and integrating into the workflow. And over the years, we have developed a bunch of best practices on how to do this work. So in 2022, we were awarded a grant from Gordon and Betty Moore Foundation to start a multi-stakeholder collaborative and gather other institutions who've been doing this work for a while and understand common best practices and surface like what are the AI adoption, life cycle management steps that health system leaders have to take to do this work. With that, we formed Health AI Partnership in 2022. Now the network has grown to about 22 different healthcare organizations, as well as we have a technical assistance program that I'll talk in a little bit as well. And we have other ecosystem partners that are not healthcare delivery organizations specifically, but think about or contribute to the implementation of new technologies in healthcare space. So our mission is to empower healthcare professionals to use AI effectively, safely, ethically through community informed. So we want to make sure we talk to these people, practitioners who are doing this work on the ground, and we want to ensure that these best practices are up to date. So we talk to them regularly to understand how these practices are evolving. We want to be the trusted partner for up-to-date source of actionable guidance. And the values that drive Health AI Partnership are we want to ensure that we eliminate digital divide, we improve patient care, and we ensure that the workplace improves with the implementation of this technology. You heard the emphasis Suresh had on technology fitting in the workflow and enhancing the work experience of clinicians and frontline providers on the ground. And the last part is Health AI Partnership is a community of practitioners. We are bringing together people to talk to each other, to learn from each other, to share challenges and learnings, and promote access of this knowledge across all organizations. Next slide, please. So what is unique about Health AI Partnership? You must have heard there are multiple other organizations, but how are we different and where do we position ourselves? So we want to make sure that at first and foremost, we are voice of healthcare organizations, from safety net organizations and underinvested communities to all the way to AMCs and well-resourced organizations. We talk to everybody. We try to understand each organization's unique challenge and surface that. We also want to inform and shape policies by raising awareness around local capacity building. That's become a big focus of Health AI Partnership, that to do this work well, to leverage new technologies at all levels of institutions, we want to ensure that the capacity and capabilities are spread across the board, and we want to upskill all of that as well. We want to develop best practices and sharing to support high-low resource institutions. So anything that we put forward needs to fit all types of institutions. We are a multidisciplinary team. So we talk to clinicians, we talk to technical people, operational people, regulatory folks, patient representatives, everybody to get their input on AI adoption and implementation. And we also have a technical assistance and implementation assistance program in which we recruit organizations who are doing AI implementation for the first time. We provide them with knowledge and advice and expertise needed through the partnership and help them through the implementation process. Next slide, please. So these are some of our ongoing programs. I would be very quick on these and go through these 5 buckets. So the first and foremost is our community of practice. So I'll go through who is in part of our community, but these are the health systems, our practice network, which is our technical assistance cohort, our ecosystem partners, and we bring them together so that they can talk to each other, participate in work groups, participate in discussions, and surface like challenges and solutions. We host a bunch of education events. 3 major events are our AI Hub, which is a monthly session focused on like operational topics for AI implementation, our real world AI, which focuses more on clinical trial evaluations of AI tools in clinical care settings. So it's more scientific and scholarly in nature. And our AI in Action is our newest series that started earlier this year, which focuses on featuring innovations and practitioners from the safety net and surface challenges for the safety net organizations. We also do a lot of advocacy work, so around like advocating for local capacity building and understanding like how implementation works on the ground. Co-creation of resources is a big part of Health AI Partnership. So when we get all these health systems together, our team here at DHI and Health AI Partnership core site coordinates multiple working groups and multiple spaces where we build frameworks for AI adoption. And then knowledge and dissemination, obviously, we do a lot of publications. We write manuscripts with our partners and collaborators, and then media relations and different talks as well. Next slide, please. So this is our community of practice. So as I was mentioning, in the biggest bucket, you will see the healthcare organization who are part of our core network. These core network these health systems are more advanced in their AI journey. They have either developed solutions or implemented AI tools in clinical practice for a while and have learned a lot from that experience. And these are our source of best practice. We also have ecosystem collaborators. So AM is part of the Health AI Partnership ecosystem collaborators, where we understand, okay, from their context and for the stakeholders they serve, what do we need to understand? We also talk to federal observers as well. So CMS ASTP follows our work and will be in contact. And some of our work has even been cited in ASTP's policy briefs too. And the Practice Network is our technical assistance program, and I'll go through that really briefly in a minute. And we also have research partners, so EPIC and University of Wisconsin is helping understand the open source tool that EPIC created called Seismometer, which helps with local validation of AI tools. Next slide, please. So as I was mentioning, the technical assistance program, the Practice Network that we have, so we recruited 5 health delivery sites across US to join our first iteration of the technical assistance program. And this is a unique program nationally. There is no other organization trying this out. Our motivation was, we've surfaced a lot of best practices. We've tried to understand how implementation of health AI works in clinical care settings, in high resource settings. We wanted to understand, do these best practices translate in underinvested or rural communities as well? So we wanted to understand, okay, if they don't, how do we want to adapt that, and what are some unique challenges on the ground there, so that we can make sure that we're also tackling the digital divide that could emerge. And so we started the Practice Network program last year. It's a free program to participate. 5 health systems. 4 of them are FQHCs, and 1 is the hospital system here in North Carolina. They joined the program and they were interested in implementing an AI solution using Health AI Partnership best practice. And we are providing them with one-on-one guidance, expert consultation, peer learning, community, educational materials, and other resources. Next slide, please. These are the 5 sites that joined us. So Community University Healthcare Center in Minnesota. They are trialing out Epic's no-show algorithm. They are in rural Minnesota. North Country Healthcare in rural northern Arizona. They wanted to trial out ambient scribe technology, and we are helping them with vendor selection as well as pilot testing as well as implementation, so advising on that. San Cedro Health is FQHC in San Diego, so on US-Mexico border, and they are trialing out an FDA-approved diabetic retinopathy screening device. And in Cleveland, Texas, the Health Center of Southeast Texas is trialing out large language model ambient scribe technology. And in WakeMed is the hospital system that trialing out Epic's no-show algorithm. Oh, sorry, Epic sepsis algorithm. Next slide, please, sorry. Yeah, and then as I already mentioned, with these sites, we co-create these resources. This includes our 8 key decision point framework, our health equity across AI lifecycle framework, which is like a framework that spans across the AI lifecycle and calls for procedures for equity assessment. We do a lot of work around creating other frameworks, and Senna will go through vendor disclosure framework in a little bit. Next slide, please. So this is our one of the first frameworks that we developed as part of like the initial cohort of Health AI Partnership. And this is the 8 key decision points. So these are the 8 steps, 8 decisions across the AI lifecycle that a health system leader needs to make when thinking about AI, implementing AI and adopting AI in clinical workflows. Under these 8 key decision points are like step-by-step guides on what needs to happen in each of these stages of AI adoption. And you can go online on healthaipartnership.org to get and under resource tab to access the 8 key decision point. These are very practical step-by-step guides that are easy to follow. And these came about by extensive interviews. We did about 90 interviews across all the health system as well as our ecosystem partners and other key informants to surface these best practices. Next slide, please. And this is our HEAL framework, health equity across AI lifecycle. So using the same 8 key decision point framework, we try to build out procedures for equity assessment when implementing AI solutions. So what do you want? What should we do when you're trying to identify and prioritize a problem? What should you do when we're defining the components of the AI solution? And we also call out what equity goals to look at each stage, what kind of stakeholders you need to involve when doing these equity assessments, and what kind of data you would need to be able to like track and conduct these assessments. So this framework is aimed at mitigating potential of AI worsening inequities. These are step-by-step guides again, trying to be very practical in applicability, and then describes engagement of various stakeholders too. Again, you can go under our resource tab to access the PDF of the health equity assessment as well. Next slide, please. And now I hand it over to Senna. Thank you.
Thank you, Alifia. So as you've all heard, at the very core of the Health AI Partnership community is developing these best practices, especially when navigating relationships with vendors. And that's the topic of discussion for today. And we really want to talk about transparency in practice as we integrate AI into healthcare. There are 2 important questions to ask ourselves. Number 1, how are AI models being used? And then the second, how do we communicate appropriate model use across the entire ecosystem from development to implementation? So when we talk about transparency, we're not just talking about the model's architecture or the training data, but we're also talking about clearly communicating what a model's intended use, its limitations are, and then also where the predictions might fail. So responsible use of models really hinges on transparency, and this often begins with a shared language that we develop, setting up expectations for all the stakeholders involved, and then also a commitment to accountability at every stage of integration into clinical workflows, like Suresh discussed earlier. So a lot of these ideas that we're sharing here is actually from our team's prior work on transparency and risk communication, which Mark actually led. So Mark, if you want to chime in at any point, feel free to do so. But I've also included the publication on this that really talks about what it means to communicate risk to different audiences within the health system and also within healthcare in general. So simply making information available through transparency does not necessarily guarantee its responsible use. And so whether we're developing a tool or we're at the point of care implementation, we want to make sure that we're using effective approaches of communication. So number one, can people find the information they need? Can they understand it in context? And also, can they evaluate its relevance and its trustworthiness? So these are the questions that we think about when it comes to being transparent about AI models, ultimately for responsible use. Next slide, please. So let's take frontline clinicians as an example audience for transparency and risk communication. It's essential that information clinicians receive is timely, it's relevant, but also actionable right at the point of care. So our team developed the DHI model facts label, and you can see that on the right here. This label is documentation that consolidates key information about an AI model into clear, concise, and standardized formats. And the purpose of it is to collate all the relevant, actionable information that clinicians, clinical end users at the front line will need in order to use the tools responsibly. Our model facts label is also aligned with the HTI-1 final rule, which mandates transparency in clinical decision supports to ensuring regulatory compliance while also enhancing usability. HTI-1 final rule has also cited our model facts label several times, and we are so glad to see the impact of this work on federal policy in AI transparency in healthcare. So in the interest of time, I will just draw our attention to three main sections of the model facts label: the user section, the direction section, and then also the warning section. So these provide critical context for safe and appropriate model use. What is the model intended for? How should it be applied? And also where it may fail or cause harm. Without this clarity, even a well-intentioned model can be misused. Next slide, please. Next slide, please. Thank you. So as I mentioned before, the primary audience of our model facts label is the frontline clinician at the point of care. We also put a QR code here on the slide for you to access the free templates, try it out. On our website, you also find an example filled out template just to see what kind of comprehensiveness is desired by stakeholders in health systems when looking at what types of information to present about a model that's been implemented. Next slide. So the other audience to consider here is the vendor engagement team within the healthcare delivery organization. This team usually is making procurement and adoption decisions and have several questions for vendors. So as mentioned earlier, the primary audience for the model facts label is a frontline clinician. However, for the vendor engagement teams, we've discovered that they require more information beyond what the model facts label captures. So this is supplementary to the model facts label. In response to this, we've developed a comprehensive vendor disclosure framework to address a two-part problem that our community of practice have shared with us. The first one, unclear evaluation criteria. Healthcare delivery organizations often do not know what questions to ask when evaluating AI tools for procurement. And then secondly, while vendors have legitimate IP concerns, there are still opportunities to enhance transparency in disclosure. So when healthcare delivery organizations request information, sometimes they receive partial or inconsistent details, making it difficult to fully evaluate the tool's capabilities, limitations, and potential risks. So here are a few terms just to help us ground the discussion moving forward. You hear me say AI systems a lot, and what I mean by this is vendor-owned integrated computing platforms and any supporting components for that. And then HDOs, so healthcare delivery organizations, are often the AI system procurer and implementer in these care delivery settings. And lastly, AI vendor, I'm referring to the system developer that is external to the HDO. All right, so to develop this vendor disclosure framework, we worked with 3 institutions. This was a work group, self-selected, volunteered their time. We're very appreciative of that. And these 3 institutions, New York Presbyterian, Geisinger, and Scan Health, have been developing their own internal frameworks to help facilitate that vendor engagement process. So we brought them together, we collected their internal frameworks, began synthesizing these frameworks for the first iteration of the HAIP vendor disclosure framework, and through a co-design process and a feedback synthesis process, eventually developed the final framework that you'll be hearing more about today. But we just wanted to make sure that you're aware this is participatory and this is the value of the Health AI partnership community that Alifia mentioned before. Next slide. All right, so the Health AI Partnership Vendor Disclosure Framework was created really to bring structure and clarity to the relationship between the healthcare delivery organization and to the vendor to ensure that right questions are being asked, but also that meaningful answers are being provided. So in the interest of time, I will not go through every single framework objective, but a major one for the health systems that we've heard from is to be able to enhance communication and also to be able to facilitate integration into their already existing workflows. Next slide. All right, so for the 2 primary users of the vendor disclosure framework are the health delivery organization and the AI vendor. On the health delivery organization side, we came up with this term of vendor engagement team. And what that really is a team of representatives from these different departments: clinical informatics, technology, legal, business operations, and a clinical champion that really understands all the necessary information needed to make an informed decision about an AI tool. We also included a secondary user of the framework, which we've termed beneficiaries. And these roles are usually clinical end users, IT support, or a health justice team, for example, that needs the information from the completed vendor disclosure framework in order to use at the point of care if they want extra context, also beyond the model facts label that we shared before. Next slide. All right, so what's in the vendor disclosure framework? As we mentioned, this is very comprehensive, but really wanted to hone in the fact that most health systems we've talked to want to go beyond the model data. They are interested in the data, but they also want a more comprehensive view of different domains to assess while procuring these tools. So just going clockwise here, starting with the first domain, system capabilities and intended use. What this domain does is establish the foundational knowledge about the AI system's functionalities, its use, and also its affected stakeholders. Then for the second domain, which is the system performance and compliance domain, it establishes the AI system's operational metrics. Here you think about performance metrics that are often reported, potential biases, associated risks, so different performance across subgroups, and also any regulatory standing if the tool has one. Then for the third domain, which is data stewardship, and as you can see here, we've highlighted that part because it has been identified as a much needed extension of the conversation around model data. So not only do health systems want to understand the model data and performance metrics, but also how to approach data governance, including data security, quality assurance processes. Secondary use of the data is one thing that we've heard a lot. And then also any retention policies that surround the data use. Then for the fourth domain, we're looking at integration requirements, which often look at the total cost of ownership and the implementation timelines needed for successful integrations into workflow. Then lastly, lifecycle management domain is looking at post-implementation. Stakeholders want to know, what are the vendor responsibilities post-implementation for ongoing support, for monitoring, and then also any maintenance services needed. Next slide. So this is a snapshot of the framework format. For every domain that I've mentioned, there's a brief description of the domain just to help orient whoever the primary user of the framework is. And then there are subdomains with direct questions that we're posing to the vendor and the vendor team. We also provide supportive descriptive statements just to make sure that we're being clear about the communication and that it can also serve as a guide in terms of what will be considered a comprehensive response to the questions being posed here. Next slide. So to give you a little bit more detail about the different domains that we have, here I've put all the questions that you can find under the domains, and I'll briefly describe what each of these are driving at. So in domain one, again, looking at the system's functionalities and its intended use, we ask questions about capabilities. You think this is very basic. What does the AI system do? We want to make sure that we're documenting the intended use and the capabilities of the tool. What are all the potential use cases? This again goes back to our point of you can have all the data you need, but if the model is misused, then there is potential for harm. So we're setting this as a foundation for both the vendor and for the health system. We also want to look at the potential impact of the system. Who are the direct users that you anticipate? This could go all the way from patients to administrative staff or any clinical staff. We also want to make sure that we're asking questions about the known limitations of the tool. What are some edge cases where the system may not perform optimally? And then we also ask questions about, inclusion and exclusion criteria. What are the parameters that determine when the tool should be used or should not be used? Here you can look at different patient populations as well. Then under the, sorry, could you state, yes. Under implementation context, as you've all probably heard, the Ambient Scribe tool right now is widely used, and I think a lot of use now is seen in outpatient care. So implementation context is also very important. So care setting, is it being used inpatient, outpatient, virtual settings? But we also ask questions around whether this should be used enterprise-wide or department-specific settings as well. And then under cadence, we're asking questions around what point should the system be used. And this question is important because if you're looking at a tool, for example, a readmissions tool, you want to ask questions like how frequently are the risk scores being reported? This is all to help also guide the frontline clinicians in terms of knowing when responses are expected and how to react in scenarios like that. And then lastly, maturity of the tool. Is it experimental or is it a well-established technology? And what is the rationale for that or evidence to back up that claim as well? Next slide. All right, so for system performance and compliance, I'm going to move very quickly because I want to make sure we have time for questions and answers. So for model performance, we're asking the questions that you hear a lot more about: performance metrics, evaluation approaches. We're looking at any differences in subgroup performance, and also the risks that are associated with the system. We're also asking questions about vendor contract expectations, making sure that we're highlighting any liability and indemnification terms as well. And for model performance and subgroup performance, we also have LLM considerations. So throughout the framework, there are some subdomains that are specific to LLMs because those can present differently. So any additional considerations for those we highlight in the framework. Next slide. Data stewardship, again, is looking at governance practices to make sure that there's security and compliance, secondary use of data, and then also looking at what the data ownership rights or transfer protocols might look like. The other part that we're highlighting here is contingency planning or business discontinuation. Health systems are also thinking about what happens during system failure. This is something we heard over and over again through our work group process is what, in case of business discontinuation, what does data stewardship look like and how do health systems adapt accordingly? So we've included questions around that area as well. Next slide. Domain 4, looking at the total cost of ownership. So this is costs in terms of upfront operational potential hitting costs, but also looking at what the personnel requirements are. Who do you need to be on the team to make sure implementation is successful? If possible, we're asking vendors to give examples of roles and expertise that they expect to support the implementation practices, but also asking questions around the integration path of the tool. So in our framework, we've developed it into 3 different integration paths. We have standalone, partial integration, and full integration, and we've provided descriptions of these for vendors to choose one if it fits into that bucket, and also to provide any associated risks based on the path that's being chosen. Next slide. For lifecycle management, we're looking at what maintenance or any ongoing support that is provided by the vendor post-implementation. So this also includes adverse event reporting, just as we do for other implemented tools within the health system, making sure that we're tracking those and being timely in responses to adverse events as well. And have also provided space for vendors to give direct contacts on their team and the expertise that they hold in terms of responding to these requests, just to make sure that there's clarity, there's accountability, and that the health systems know who to reach out to in terms of any adverse event that comes up. Next slide. So these are some use cases that we've heard from our work group in terms of framework implementation. They will use this to guide vendor screening and evaluation to support their RFP process, all the way to also supporting regular performance reviews, since we have a system performance domain where metrics are being reported. Next slide. So currently, our practice network sites are adapting this framework and using that to facilitate their vendor engagement. And we were hearing from them that, it's equally important to also be able to interpret this information that is being provided by vendors. And so that's something that we're thinking actively about as we think about the next iteration of this framework and how to better support the primary users of the framework. We're drafting a manuscript internally for public release, hopefully in the next 2 months. Next slide. And these are some key takeaways. This is really to help build trust in that vendor relationship with the HDO, to support informed decision-making, and to make sure that clear documentation is helping to reduce any misuse, misunderstandings in these relationships and engagement, and also any potential harm that might come up. Thank you. We will take questions.
All right, amazing. Thank you all for all that discussion. So some really key topics that came out of there. I have a couple of big questions. The first one is more fun. I saw the Shark Tank versus the dolphins. Is that an allusion to that your investment reviewers are less bloodthirsty than sharks, or is that just a different version?
No, it is exactly that, in the sense that this is about internal dollars that's coming in to really support and create a culture and foster a community of both innovators and entrepreneurship. So yes, it is a dolphin tank, truly, in the sense that want to support to enable them. That's why we call it a dolphin tank, even though it's supposed to be like a Shark Tank model. But yeah, that's
great
in terms of fostering a culture. Yeah.
I love that. And the value creation slide that you had is just incredible. Like, there are so many different problems to address, and it seems like this model is really equipped to handle a lot. And so big kudos to your team for being able to handle so much there.
Thank you, Dennis. For that, I want to mention something, which is we have been developers as well. So we share some of the same set of thought process, what it truly takes to put something into practice at the same time. We play the other side and say, if I'm going to use something within our system, what is truly needed as well. So we come from it from both sides. So excellent.
On the AI side, one of the questions in the chat talked about, what if someone doesn't answer the label questions or doesn't fill out the disclosure questions? And so kind of piggybacking on that, I guess, what's the benefit to providing all that information? What's the cost of not doing so? And then you did call out specifically who you expect to use those aspects of the label. But I imagine that there's also several teams that would use different aspects, right? Like somebody who's going to implement the model versus someone who's going to trust the outputs of the model. Can you speak to those a little bit?
Yes, the word that you mentioned were trust. I think that's the most important point, and then everything else falls into space. I'm going to ask Mark and Senna to comment on this. Yeah.
I was just going to say, I think the reality of the current environment is that there's not going to be a lot of kind of federal action to establish standards or regulation. So we see this as an opportunity to create norms in the industry. And there was already an enthusiasm to do that amongst the mature organizations. And part of why we're putting together a manuscript is to also make public the call to action that this is something that people building in the space should know about and should be aware of, because if they're getting asked to fill out these forms, which many already are getting those questions, at least they can start preparing for it. And honestly, I mean, I'd be open, I know we just have a minute, but I feel like it's better if we can at least draw a line in the sand and say, okay, here's what to expect, then leave it up to every organization to develop their own questionnaire that will just take more effort from developers trying to interface with these different systems.
Got it. That makes a lot of sense. Like, a system needs to trust that somebody bringing an AI to the table is doing so responsibly. Do you think that, and so a big question there is, how early in the life cycle of development should entrepreneurs be baking these questions in and thinking about these frameworks? And big picture, are you encouraged by the collaborative support? Are you cautiously optimistic? Like, what's your sense of how people are responding to these?
Go ahead, Senna.
Senna.
Yes, I am very encouraged by the response to this. I think what it does is set the expectation on both sides. What we want to do is make sure that these expectations are set, that there's a shared language that health systems can use, like Mark mentioned before. They might adapt it for their own system, but this is a place to start, and it's so comprehensive that there could potentially be every question you could think of, but changing it for the health system is helpful as well moving forward in terms of the engagement with the different vendors.
Like Senna mentioned, it is a starting point, and it is not just for these type of AI tools. It is for anything that's going to come down the pike as well. This would be a starting point, and then we would iterate and evolve over a period of time. This is not set in stone. I think things are moving at such a fast pace. We need to be open to changing and adding and removing things as well.
All right, fantastic. Thank you, Duke team. This has been really helpful. Everyone on the call, we'll send out a survey afterwards as well. If you could fill that out, we'd appreciate it greatly, and always open to more input. Thank you, everyone.
Thank you,
all.
Duke team, again. This has been a pleasure. Great session and information. Thank you. Bye.